when I look at the responses from the women in our community who have answered our signs and symptoms survey, and that's almost 5,000 of you. So for those of you who have taken the time to answer it, thank you. For those of you who haven't, please do just take a moment. It's below, because once I get to the 5,000 mark, I'm going to publish another white paper. So that's really exciting. And what I found is that more than 50% of you have said that you struggle with weight gain and metabolism changes now that you're in perimenopause or menopause. And it's a very common symptom. And it's something that weight has been an issue for me for a lot of my life. And it's something that I've been struggling with in the last little while, ever since in 2022, when I had my bout with Hashimoto's and I lost a lot of weight in a very short amount of time. I gained it back, and then I gained back quite a bit of extra weight, and it threw off my thyroid. It created inflammation. I mean, it created a cascade of things that happened in my body, which all contribute to metabolic dysfunction and weight gain. And in the book I'm writing, I talk about minimum of 15 different things and reasons as to why we're putting on weight in this phase of life. So I'm excited about today's guest, because today we are talking about our metabolism, and we're talking to a naturopath who I have so much respect for. So let's get into it. But before we do, I'm going to quickly introduce myself. If you're new to my podcast, my name is Andrea Donsky. I'm a nutritionist for almost 20 years. I'm a menopause educator and menopause researcher, and I'm the co-founder of a company called wearemorphus.com. So our goal is to empower you to take control of your health and symptoms with nutrition, lifestyle, supplements, and research. Today I'm speaking with Lara Briden. She's a naturopathic doctor and the best-selling author of the books Period Repair Manual, Hormone Repair Manual, and the Metabolism Reset, or Metabolism Repair for Women, which she'll talk about why there are two different titles for the same book in a minute. She currently has consulting rooms in Christchurch, New Zealand, where she treats women with PCOS, PMS, endometriosis, perimenopause, and many other hormone and period-related health problems. I hope you enjoy my interview, because Lara is awesome. Now, here she is. Welcome to Menopause Reimagined, Lara.
Hi, thanks for having me.
I'm excited because the last time I interviewed you was for our summit back in, I think it was like 2021, which was a very long time ago. And I'm excited that you're on my podcast, Menopause Reimagined, because you have a new book out, and I would love you to show it to everybody. I talked about it in the intro, Metabolism Repair for Women, which is the
Yep.
North American name. There you go. See, for those of you who are
Yeah.
listening on our podcast, you can go over to YouTube. You could see Lara's showing it. And I know, what's it called in Australia and New Zealand?
Yeah, down under it's the Metabolism Reset.
There
So
you go.
it's two titles, Metabolism Repair for Women and the Metabolism Reset, same book. It's just different, different titles.
I love it. Okay, so what inspired you to write it?
For me, this was going deeper into women's health. So my real passions are menstrual health, hormonal health, PCOS, perimenopause, and thyroid and things like that for women. And metabolic health is kind of the next level down. Like, it does affect lots of aspects of women's health and vice versa. There's a lot of crosstalk. So women's hormones can affect metabolic health. And I just felt like, yeah, this is a conversation I'd like to have with my readers, to try to explore what is, on the one hand, seemingly quite a simple topic. Is like, oh, surely you just have to eat less and exercise more. Obviously, that's not what I think. And on the other side, it's actually an incredibly complicated topic. So I've tried to find an in-between place where I've tried to explain some of the complexity, but at the same time, always just keep bringing it back to, what do you need to do? How do you troubleshoot this situation?
You know, like you said, it's very complex, and it's also a touchy subject, right? So I know that when I talk about weight gain, especially as we're going to perimenopause and menopause, I try to be super gentle about it. And also for women who had eating disorders their whole life, right? So it's one of
Sure.
those things, like, you're right. It's not just like eat less and exercise more, which
No.
many of us are told as we go into this phase of life. And many of us are gaining so much weight. Like, our research shows, we have these research surveys, and one of them has almost 5,000 responses, which is our signs and symptoms. We know that over 50% of women in perimenopause and menopause are gaining weight. So it's a very common thing. It's something that I'm asked all the time about, which I'm guessing you are as well from your patients.
Yeah. So a couple things to say about that. You're right. It's a tricky topic. I have a whole chapter on that. You would have seen in the book about dispelling the shame, sort of just reframing this all. This, I guess, one thing to say is that my read of the research, and I do talk about this in the book, is really arguably the metabolic dysfunction comes first, and in some people can lead to weight gain. But interestingly, people can have metabolic dysfunction and still be a small body size. So they're not like exactly tied together. And that's very different from the old narrative, which is that people just gain weight because they're lazy or just that sort of thing. And then that leads to metabolic dysfunction. It's actually the other way around. The metabolic dysfunction is being driven by, all the scientists agree, by various factors in our modern environment. And that's why chapter 1 is called, weight gain is not your fault. Um, yeah, and the
Yes.
second thing about perimenopause, menopause, there is a big change in metabolic health, huge. Like some of the papers describe it as a time of metabolic upheaval. There's a recalibration of the metabolic system, just as there is of every system during the perimenopause transition.
And I know you talk about insulin resistance in your book, something else that
Yeah.
we're very prone to, again, part of that metabolic dysfunction. And what's interesting, and you were mentioning it before, that, a big passion of yours is PCOS. And what I don't see spoken about enough is the connection between PCOS and insulin resistance and menopause. And
Yeah.
and this is something, and the reason I'm saying this is because I have PCOS. I've had it my whole
Yeah.
life. I have trouble with fertility. And then I have, now with insulin resistance and menopause. So, and the weight gain, like it's all interconnected. And I would love you, to talk a little bit about that, because it's an area that I feel needs so much more attention than it gets.
Yeah, there is lots of overlap. Um, the first thing to say is that hormonally and metabolically speaking, PCOS and perimenopause have some similarities. They're obviously not the same thing, but they have some similarities in that they're both times of insulin, can be both times of insulin resistance. They can be both be times of, as I describe in my new book, Metabolism Repair for Women, and my perimenopause book, Hormone Repair Manual. Perimenopause is a shift, can be a shift, well, basically is a shift to what's called what I call testosterone dominance, or relatively high androgens or testosterone compared to estrogen and progesterone. And that in women, even relatively high testosterone can drive or worsen insulin resistance. So that can be mitigated by all different, factors, including hormone therapy, but not only hormone therapy. So there are definitely things to be done. So that's one overlap between between PCOS and perimenopause. But the other thing to say is that PCOS is interesting in that it's, well, as I've described in some of my writing, it's not one thing. So lots of different women get, given the label of PCOS, and some of those women actually outgrow it to a large degree. So it might just be something that they have when they're young. And then as they get older, the androgens go down and they establish normal cycles, and it kind of is reverse is gone. But that's not always the case. Some women, if they have tended to insulin resistance and androgen excess when they're younger, that can 100% just keep going and progress into perimenopause and potentially worsen, and yet sometimes be missed, because this comes back to the little, naughty ultrasound finding that is confusing everyone, because you can, just in terms of the ultrasound finding of polycystic ovaries, lots of young women have polycystic appearing ovaries on ultrasound, and they don't have PCOS. Conversely, primarily just because we have fewer follicles or eggs as we get older, women in their 40s can have definite PCOS, and as in androgen excess, as in anovulation, as in insulin resistance, and not show polycystic ovaries on ultrasound. So it can be missed that way into women's 40s.
Can you just give a quick explanation? Because I use the acronym, and I'm like, well, what if people don't know what PCOS is? Because so if you
Right.
just
Yeah,
like,
true.
sometimes I think I'm like, well, yeah, it's part of my life. It's what I live with. But yeah, if you could just give a quick definition of.
Yeah, that's a good point. So polycystic ovary syndrome, most people agree it's misnamed because it's not about cysts on the ovaries, despite the name, but it is. Some other names proposed are androgen excess um, syndrome, or the condition of, and I think my favorite is Professor Pryor's definition, which is anovulatory cycles with androgen excess, or something like that. So this is a situation of, I think by definition there has to be higher androgens or testosterone, which can either show up on blood tests or in symptoms like facial hair or tendency to acne or hair loss. And then usually along with that, some difficulty in having regular cycles, menstrual cycles. Although it is always, as you know, it is always possible to have menstrual, to reestablish regular menstrual cycles. And typically women who have that kind of lifelong PCOS will start to become more regular as they get older. Actually, I've had women with PCOS in their 40s tell me this is the most regular cycles they've ever had, or that, sort of 8 or 10 years leading up to menopause.
Yeah, it's interesting for me. It definitely, for trying to get pregnant with my first baby, I had a very hard time, but then afterwards I had no issue. And then I had a regular cycle, but then I was taking bioidentical progesterone,
Yeah.
topical many years. I had seen a doctor years ago who put me on it. And so that helped with it as well. So I just find PCOS super interesting. And I find it interesting also in relation to insulin resistance and just everything that kind of, as we go into menopause, like, oh, everything's shifting and changing, right? So all these things.
Yeah.
So I'd love you to talk a little bit about insulin resistance and what it
Yeah.
is. And then I know that's a big part of your book. So if you could share
Yeah.
share what it is, and then what can we do to help for those of us who are insulin resistant or having issues with blood sugar regulation that could be
Yeah.
contributing to the weight gain.
Yeah, let's talk about insulin resistance. And I keep saying every interview I've been doing the last couple of weeks, I'm trying to brainstorm with the host. What could a rebranding for insulin resistance be? Because the name itself, people somehow seem resistant to it. Like it's sort of a tricky name. So I guess I might rebrand it as like something amiss with the energy system syndrome. So it's really it's really a problem with how the body handles energy. And I'll explain that a little bit more. It is associated with chronically elevated levels of the hormone insulin, even though in the early decades of insulin resistance, blood sugar can be totally normal. And in fact, women can tend to episodes of low blood sugar, which kind of, goes against the idea that insulin resistance is prediabetes. Insulin resistance can progress to prediabetes, but it's not synonymous with diabetes. So blood sugar can be normal. So that's important to know about that is a normal blood glucose reading on a on a standard blood test cannot rule out insulin resistance. Instead, in the book, I talk about how to test it. You can measure the hormone insulin. You can look at things like high triglycerides. You can look at there's a biochemistry marker called ALT, which I'll just, mention. It's pretty associated with insulin resistance. Fatty liver is a classic sign of insulin resistance. But what it is, it's it's way down in the nuts and bolts of the cell. Like the mitochondria are not sort of being able to flip as they should between burning fat and burning glucose, largely to do with this kind of chronically elevated insulin situation. And that leads to people, I guess in a nutshell, I would say like people not being less able to access their own body fat for energy, which is hugely important because what that translates into, not only harder to burn fat, which is harder to lose weight, but not having the energy you need because our healthy default is we're supposed to actually be in kind of just a mostly fat burning state all the time unless we exert ourselves or go into higher levels of exercise, in which case we'll switch more into carb burning, although we're always burning a mix of the two. But with insulin resistance kind of being locked in this carb burning mode, this is why people get so hungry. It's like they get kind of, you have to eat every 2 or 3 hours because their blood sugar is crashing. This is a classic sign of insulin resistance. So I hope that's made it a little more clear to people why it really should be on their radar. It depending on who you ask, insulin resistance probably affects about 40% of people, adults in our modern world. And that's that's way higher than it used to be even 50 years ago. So there's something has gone kind of fundamentally wrong with metabolic health for the majority of people, which is actually really quite concerning, which is the other reason I wrote this book is this is affecting a lot of people. And it's not just about weight. It's about all the potentially downstream consequences of untreated insulin resistance, and eventually then prediabetes can increase the risk for heart disease. That's the big one. It probably does increase the risk for dementia, osteoporosis, potentially cancer. I mean, not to like scare people, but some of our, our big, what I call in the book, the big three, heart disease, dementia, and cancer are all things that associated with this, with insulin resistance, although then there are other causes of those conditions, of course. So it's both. I really am trying to raise awareness of it and also, not scare people too much about it.
No, and I know
Yeah.
that it's like that delicate dance, right? But at the same time,
Yeah,
definitely, I do believe that we need to take control of what we can take control of, and
yeah,
certain things like nutrition, lifestyle, certain things that can contribute to it, we can, and then there's a lot we can't that is out of our control, right? So, and
for
that's where the
sure.
not your fault comes in, right? Especially as we go into
Yeah.
it's frustrating.
Well, one of the things that is not in our control that's already happened, and I'll just frame this, is that um, there's something called epigenetics. People don't need to, get too worried about the technical term. It just means that changes. So what's happening is the last 3 or 4 generations that have been subjected to something wrong with the food supply, something wrong with the environment, that is probably a combination of food, ultra processed food, environmental toxins, is pushing everyone, especially people who are genetically vulnerable, into way more risk of insulin resistance. And what epigenetics means is that exposure is essentially passed on to the next generation. So genes get switched on and off, that gets passed on. So the risk for insulin resistance is amplifying each generation. And what that means is people who born in the last couple generations are just way more at risk of this metabolic problem than collectively we were even a couple generations ago. So that's already happened. So there are people who are just, yeah, almost from birth basically, and from before birth arguably, gonna have just gonna have a harder time and have to make more concerted efforts and changes and not be able to get away with, what people could do even a couple generations ago. I mean, eating, junk food is not new. Certainly, 50 years ago, people were eating a lot of sugar as well at times, but this is, we're more vulnerable to it now. So I hope that, yeah, that it speaks to what you're just saying about it's not our fault. And there's lots of other factors too, right? There's medications affect metabolic health. Our gut and microbiome have a huge effect. The nervous system does. Female hormones do. Hormonal birth control affects it. So this is where the troubleshooting comes in, is for people to try to identify, of all the 25 different what I call metabolic obstacles that I list in the book that are potentially standing between them and a return to metabolic health, is being able to identify those and then address them with hopefully not too like onerous changes. It shouldn't have to be too hard.
And stress too.
Stress, circadian disruption. Mm.
Yeah,
Yeah,
lack of
ultimately the nervous system is in charge of metabolism. I mean, hormones are a factor, but through my lens, looking at all of this, I'd say that the nervous system is the big boss of all of this. So there's lots we can do to help with that.
So what are some things that, so you were mentioning a lot of things that we can do. So what in your book do you talk about that if somebody's right now is saying, okay, that I know that I have insulin resistance. I
Yeah.
know that I have some weight that I'd like to lose. What are some tips that you could share? Of course, everyone go read the book, please. We'll put a link to it below, but
Yeah.
this will easily pretty much anywhere.
Yeah.
There's the book, wherever you're listening
Yeah.
to the podcast from. And so what are some things that you could share that people can walk away with and going, okay, I could do this. I could do this.
Yeah. Um, yeah, no, it's good. I think, well, I'll start with the nervous system because I just talked about how important that is. I mean, so taking, some simple steps to align circadian rhythm can be a nice first step because you just feel so much better when you get that outdoor light and, shelter from blue light at night and time your protein, like the timing of protein throughout the day can really affect circadian rhythm. So a morning, by 10 a.m., having some outdoor light and a big serving of protein, like 20 or 30 grams in the morning, can make a huge difference for not only how the nervous system is, but how obviously the underlying metabolic health. So that's a good number tip. I mean, tip to start with. I do offer what I call the a discussion of the 5 missing metabolic nutrients. And again, through my read of the research, and there's more than 5. Obviously, our diet used to be a lot more nutrient dense than it is now. But I do talk about the value, and all of them are inexpensive. All of them are safe to try. They can be taken in some combination, or you could just start with the first one, which is magnesium. So I'll just list the 5 because
Yeah.
you don't have to buy the book to learn about the 5 or to hear about the 5. You can learn more in the book. But so magnesium and taurine, which is this combination that's been pretty well researched for supporting metabolic health. It was in both my previous books. Taurine is an amino acid that is just improves insulin sensitivity, helps the mitochondria. The mitochondria are big players in all of this. And then the other 5, the other ones are the next one is inositol, which you know all about with PCOS, polycystic ovary syndrome. Inositol has actually been also clinically trialed for the weight gain of perimenopause. And then the final 2 that I included in the 5 are choline, which is, I'd say, a missing nutrient. We used to eat a lot more organ meats, uh, which are
Eggs.
high in choline. Eggs are also high in choline. And then the last one is glycine, which is, I'm seeing getting a bit of traction. Something must have happened on TikTok with glycine, because suddenly everybody's talking
Oh,
about glycine. I
because it's
love it.
magnesium glycinate. It's like the
Well,
hot
it's
trend.
in magnesium glycinate. You can also top up with some extra glycine in the evening.
Yeah.
It tastes sweet, which just tastes like sugar, which is quite weird. It's not sugar. And you just take a little, bit of powder, like shot of that before bed, and it can really help with sleep. It also shelters the liver from high dose fructose, and, you know, it lowers inflammation and does really good things for metabolic health. So I mean, I'm a naturopathic doctor, so I'm a fan of supplements, and I like those 5 because they're
Yeah.
inexpensive, easy to access. And I don't, just for everyone listening, I don't sell them myself or anything. You can get, I list a few brands at the back of the book. So that, and then I do talk about, I mean, obviously it's still important, we have to build muscle. I frame it that way, not doing exercise to burn calories, nothing like that, but moving the body to build muscle and help the nervous system and all the things that some kind of regular movement can do. I'm a bit of a agnostic in terms of what type of movement. I've confessed a couple times that um it's funny because I mean the research is pretty strong for strength training, and I'm on paper, I love that, and I think it looks, sounds great, but I'm not doing a lot of that myself, apart from some resistance bands and lunges during my yoga practice. So I do just want to encourage people to find the type of movement they like start with that. I provide about, I think it's a list of like 30 or 40 descriptions of movement that my social media followers enjoy and why they like it. And it just gives people a nice menu to choose from. And then there is always going to be some degree of, getting what you need in terms of protein, in terms of, vegetables and these missing nutrients, and then sheltering from what you don't need. And I guess, that has to happen too. That often putting in place all those other things I've talked about can help with this step of sheltering from the foods that are harming us. And those foods would be, I mean, no surprise, but high dose sugar, I would put vegetable oil in that category. I guess what we call seed oils, I'd put that in
Seed
that
oils.
category, and that's in
Okay.
all processed food.
Yeah.
Um, yeah, and alcohol, sheltering from those things on a consistent basis. And sometimes extra help is needed for that, especially if there's food addiction.
I like how you say sheltering. It's a
Yeah.
great
Yeah. Yeah. Rather than, giving up or abstaining, like, it's like, protecting
avoiding.
yourself, protecting your metabolic, protecting your mitochondria
Word.
from those foods. Yeah.
It's
Yeah.
a great way to say that because you're not like avoid, avoid. You're like shelter
Yeah.
yourself. So
Yeah.
it's like a lighter, more gentle way to say it, which I think is
Yeah.
great. And
Yeah.
definitely, things like alcohol and,
Yeah.
ultra processed foods and sugars and carbs, like anything that's ultra processed definitely has that negative effect. And I'm happy that
For
you talk
sure.
about seed oils too. I've interviewed Dr. Kate Shanahan many times.
Right.
So she's amazing. And she talks about that and how seed oils actually contribute to weight gain and oxidative stress in the body. So it's
Well, they seem to be that high dose omega-6. Honestly, if you look at the research, I know it's controversial. I'll give a nod to that. I don't get that there's some people out there really trying to argue that it's okay, but I think the writing's on the wall. There's something gone very wrong with that much. omega-6. I think it's the way it's out competing not only omega-3, but potentially some of the beneficial saturated fats, such as something called C15. It's a type of saturated fatty acid that's quite metabolically beneficial. And yeah, like there's worrying suggestions from some of the research that, our collectively, our basal metabolic rate has lowered in the last few generations, has reduced. So we're actually just all burning less energy than we're supposed to. And that some of that might be seed oils. And scientists still have to work a lot of this out, but I avoid them. I mean, to be fair, I have for a long time. So, decades ago, maybe you were the same. Like I thought, yeah, I'm sticking with butter. I'm not having any of that, vegetable oils spreads. That's not, and I'll just point out to people, even the olive oil spread down here, everyone's got these olive oil spreads. I'm like, that's not olive oil. It's like 20% olive oil and 80% like just something else. They don't even list what it is. It's whatever cheap vegetable oil they could access at the time. So yeah, and that would be vegetable oil would be in all commercial, salad dressings and sauces and things. Yeah.
For me, when I
Yeah.
consume seed oils, and I'll talk about me personally, like you were saying, the
Yeah.
controversy, but I'll talk about my own personal experience.
Yeah.
When I consume seed oils, and we're talking canola, corn, cottonseed, safflower,
Yeah.
sunflower, soy, rice bran, or grapeseed, when I
Yeah.
consume them, I could feel the inflammation in my body. Like I could
Yeah.
feel it in my feet when I wake up in the morning, like the bottoms of my feet are hurting me. It's like
Yeah.
weird sensation in the bottom of my feet. And so I could feel it just from myself. And I'm like, well, I can tell that it's creating inflammation in my body. So I'm just happy you included it because I think it's
Yeah.
it's an important ingredient for people to know about. And I'm happy
Yeah.
that it's in your book.
Yeah. Well, that's great. Yeah. Thanks for that. Yeah.
Yeah, I'm a big supporter of that. So of getting of sheltering from seed oil.
Yes. Shelter from seed oils. Yes. I think, and that's something quite, well, on the one hand, it's simple, but on the other hand, it's not, it can be not that simple depending on, because you have to then cook at home.
It
I
is,
mean,
yeah.
it's really, if you can't eat out very much at all or buy any really prepared foods and shelter from seed oil. So
Tough. And for women in this phase of life, so many of us have, again, we're more prone to inflammation in our body, right?
Mhm.
So it's if there are things, little tips that we could do that can help to minimize that inflammation, all of that makes a difference. I want to talk about hormones since you're the hormone expert
Yeah.
and you've written books on hormones
Yeah.
and working perimenopause and menopause and the whole HRT. And I know you talk passionately about progesterone. What
Mhm.
role let's go back for a minute
Yeah.
and talk about the role that hormones play when it comes to waking and our metabolism.
Yeah. So I would again, let's talk about the role they play in metabolic dysfunction and insulin resistance and the weight gain that comes from that, which is hypertrophied visceral fat or weight gain around the middle, as opposed to subcutaneous fat. They really are very, very different physiologically. Like they couldn't be more different, actually. So here's an example: like female bum fat is actively anti-inflammatory, arguably. It's doing quite good things. Um, and probably acts as a reservoir of omega-3 in the body. Like it's doing lots as opposed to visceral fat. And just to be clear, visceral fat is not the kind of jiggly fat you see on the outside of like the rolls you might see on your belly. Like, that's still subcutaneous fat. Visceral fat is inside. It's this solidness. It's kind of, people describe it as this like really uncomfortable feeling under their rib cage. That's visceral fat. And that's the fat that is actively harmful to health, actually. And it acts as its own endocrine organ. It actually starts speaking to the brain and making you hungrier. And so in terms of what your question about what do female hormones do to body fat, I guess, and to metabolic dysfunction, well, estrogen, even normal healthy levels of estrogen, does promote subcutaneous fat. So that's actually not a bad. That's good. Like that's that's as a young woman having lots of estrogen, like that's having bum fat from that and hip fat. That's beneficial. So on the one hand, you could say that estrogen promotes fat, but it's a good kind. But at the same time, all that estrogen, as when we're young, does protect from insulin resistance. It improves insulin sensitivity. It reduces visceral fat quite a lot. So that's the hourglass shape. That's the low visceral fat high bump fat from estrogen. So estrogen's good. Estrogen's like a metabolic superpower, really. There is always a nuance, like at very high levels, whether, some form of, and potentially the synthetic estrogen in the pill can do something different things. So there's more to the estrogen story. In certain situations, estrogen can promote insulin resistance, but at normal healthy levels, it prevents insulin resistance or treats insulin resistance. And then progesterone is, and again, I'm talking about real progesterone that the body makes, body identical progesterone, or the body identical progesterone you can take that you took as a cream for years, or that people can take as like Prometrium, or in Canada, the body identical capsule. Progesterone is also, I would argue, metabolically healthy. I have quite a big section about it in the female hormone chapter. So it's a little different in that it doesn't actively improve insulin sensitivity the way estrogen does, but it does boost metabolic rate in lots of other ways. It increases body temperature, it increases thyroid hormone, and it helps with mood, it helps with sleep. So it, can reduces stress. So those are all ways that it is
Right.
metabolically beneficial. And also, importantly, both estrogen and progesterone have an anti-androgen effect. So kind of circling back to what we were saying before, in women, but not in men, this is where there is a definitely sex difference in this. High testosterone will promote visceral fat and insulin resistance. In fact, visceral fat, the other name for visceral fat is android fat, which is the male type fat. So that's where I talked earlier about the overlap between PCOS and perimenopause. So during our cycling years, if we're having natural periods and making natural estrogen and progesterone, we're going to be having these metabolic benefits from them every cycle. Hormonal birth control is a totally different story, so we can circle back to that. But the hormones themselves are beneficial, and then that's where the perimenopausal metabolic upheaval starts. As we first lose progesterone, I think we lose some of the metabolic metabolism enhancing effects of progesterone, and then definitely in the later phases of perimenopause, as estrogen reduces, not to zero, but does reduce, we lose that superpower. But just to be fair, that doesn't mean you absolutely move into insulin resistance. It only means you lose one of the things that was protecting you from that. So you then are left with, you have to sort of work with some of the other ways to improve metabolic health. But I hope that I'm a big fan of both estrogen and progesterone. From a metabolic perspective, they're both, very beneficial.
So for women who are taking, let's say, their own hormones and menopause hormone therapy, and I've heard some women who have said that they gain weight taking it. So if they gain weight, is it just they've got to adjust their dosages, or like talk a little bit about for the women who are currently taking hormones?
Yeah. And there's always going to be an individual variation. So just talk about progesterone alone for a minute, and I'll talk about estrogen, of course. I'd say it's hard to get the number. I don't know the numbers on it. No one knows the numbers on this exactly. I would say the small majority of women taking progesterone on its own will lose weight from that. I mean, that's why it's now recommended. Professor Pryor has done a clinical trial of progesterone for PCOS. It's funny, you were doing it decades ago, but she's now clinically trialing that. Cyclic progesterone therapy for PCOS generally promotes weight loss, although some women feel like it causes weight gain. So I think there's going to be some individual variation in that. The one research study there is using natural progesterone combined with estrogen for perimenopausal menopause therapy found either that combination of natural estrogen and natural progesterone causes either weight loss or no change. That citation is in my book. Estrogen generally should promote visceral fat loss, kind of like weight loss around the middle. And I think that's pretty consistent. Most people would notice that. The type of hormone therapies that can cause weight gain, visceral fat gain, would be certain progestins and testosterone. And I always couch this in a bit of caveat. I mean, I understand some people maybe like taking testosterone and they found, their mood improved on it, or their libido, or, that's that's fine. I think it's probably in terms of from a metabolism perspective, I think a small dose of testosterone is okay, maybe metabolically neutral, as long as it's combined with both estrogen and progesterone, never taken on its own. In that case, it can be metabolically neutral. The other hormone is DHEA. I don't know if anyone out there is taking
Wow.
that, but it's
We've talked
metabolically
about that.
beneficial. Yeah.
Yeah, I'm a
Even though
fan.
it's an androgen, I think it does improve metabolic health, can reduce visceral fat. So
Can
yeah,
people with polycystic ovarian syndrome or PCOS, can they take DHEA?
it's a good question. I mean, I think that is a good question. It wouldn't be my first choice to go to, but again, by the time a woman's in her 40s and into perimenopause, androgens are quite a bit lower, and I think there could be a way to take DHEA safely, low dose DHEA safely in that sense, and get some of the benefits from it without aggravating any of the androgen symptoms. Yeah.
I actually like it because I was on hormone therapy for a while and it just didn't work out for me. So
Yeah.
I switched to DHEA, and DHEA raises progesterone, estrogen, and testosterone for me. So it actually works in a roundabout way. And because my androgens are so low now, it's
Feels
interesting.
good.
Like my whole
Yeah.
body now being in menopause and having had PCOS for so long, it's like a whole other system, right? So, and
Yeah.
it happens, right, when we go through
Yeah.
menopause. So
Hmm.
interesting.
Yeah, no, that's great. No, I was good. I'm glad I mentioned DHEA then, because that's to be fair, I'm taking DHEA too. So we're both I'm taking a little bit of it. Yeah, just for it helps a little, that little dusting of androgen can help with mood and muscle mass. And as you say, yeah, it does convert to the other hormones, which is why it's funny because about 15 or 20 years ago, there's quite a bit of research around DHEA and menopause. And I thought, oh, this is going to be the next best thing for this is going to be great. This is going to be a thing for menopause. And then the they pulled the plug on the research, and I don't know why, and I don't know if it was just because I'm not sure, I'm just speculating, like, it does convert to other hormones, so that probably complicates the research. And then I think maybe the other reason why DHEA has not been embraced by the mainstream is because I hate to say it, but because naturopaths like it. So I think anything that naturopathic doctors get really into, like progesterone or DHEA, then kind of tarnishes those for the rest of medicine. They're like, oh no, that's the thing that, like, natural doctors use, so we don't want to use it. That's me just thinking out loud, but it's a shame. It's a shame that DHEA isn't more researched and, made available to women.
So, Laura, let's go back to birth controls. I know you said let's park it for a minute. So let's go
Yeah,
back,
circle
because I'm
back.
sure there are women who are listening who, yeah, let's circle back to that.
Right. Well, some of the progestins are testosterone-like or androgenic. So the big one, the most common one, is levonorgestrel. There's some other ones too that, and I do list them in my book. The androgenic or testosterone-like progestins can cause weight gain, basically. I mean, not in every single woman, for sure. There's always individual variation, but as a trend, those are the metabolically negative types of hormone therapy. Unfortunately, some types of menopausal hormone therapy are still using progestins rather than progesterone. So I guess that's one thing to think about, as well as hormonal birth control. And then the other aspect to hormonal birth control that's metabolically negative is that it not only is putting in place this testosterone like progestin, but it's robbing the body of estradiol, our main estrogen, and progesterone, because by switching off ovarian function, you're not making these hormones that are metabolically healthy every month. So that's my primary objection to hormonal birth control. I guess, as for completeness, I'll just say some progestins, the anti-androgen ones, like drospirenone is probably the big one. That's in like Yasmin and that type of medication. They generally cause weight loss, which I wouldn't say is necessarily a big endorsement of them, because they also cause anxiety and other problems. So I don't know if it's worth it, but like those people, I have followers or patients say, oh, I lost weight on the pill. I'm like, which pill was it? It's almost always one of the anti-androgen ones. So and those are the medications they use for PCOS as well. So that kind of
Hmm.
fits with that. Yeah. So, I mean, obviously, I think there's way better methods to avoid pregnancy and manage period symptoms than hormonal birth control.
Is there anything that we didn't talk about that, I mean, I know everything is in your book, and again, we're going to link to
Mhm.
it below, but is there anything else that you want to leave our listeners with? Be like, okay, I want you to buy my book because you're going to
You're
learn about
right.
this.
Well, I guess the the strength of the book is, I hope, is that it helps people individualize what they need to do. And so the book also, just a couple, we won't have time to go into detail, but I do also talk about the role of food sensitivities. And I talk about the role of digestion and digestive health. And I'll just say, as a clinician, and I've, surveyed all the other clinicians through the years, and, you can chime in on this, that we've all had those patients where there's been some kind of digestion problem. SIBO would be a big one, or stomach issues, and you fix the digestion, like with herbal medicine or whatever treatment we decide to do, and then the person just drops 10 pounds. Like, appetite sort of regulates and metabolic rate increases, and it's just this natural downstream effect from fixing digestion. So that's an example of how dynamic the system is. Like, I guess my takeaway is metabolic health is not something to be like worked on the side. It's not just about, as we talked about, definitely, it's not just about dialing up or dialing down calories. It's not about that at all. It is a whole body project. So whatever the part of your health that needs fixing anyway is the part of your health that needs fixing for metabolic health. And you can trust that by addressing what needs to be addressed anyway, you're going to get just downstream benefits on your metabolic health. You're suddenly going to find it's a lot easier to not snack. I'm feeling a lot better with my meals. And, I feel like exercising more now. And it's just, my body's just changing shape kind of on its own without having to micromanage it. That's the main takeaway from the book.
How can people get in touch with you, Lara?
Oh, thanks, Andrea. I'm easy to find. My blog is larabriden.com. All my social media is at Lara Briden. I have a YouTube channel as well with a few things on there. And this my 3 books. So Period Repair Manual, Hormone Repair Manual, and then this one, Metabolism Repair for Women.
Which, by the way, your books they should be books on everybody's shelf, because depending for, whatever age you have, if you have daughters, like teenagers, in my house, I have 2 teenagers. So your books are so great for all different age groups. So thank you for doing what you do. Really, thank you.
Oh, thank you.
And thank you for doing this today.
Great to see you again.
I hope you enjoyed my interview with Lara Briden. She is amazing. She really is an expert when it comes to hormones and metabolic health. So I put a link below that you can get her book. If you enjoyed the interview, please share it, because the more you share shows you care. I appreciate you spending the last little bit with me. I know there's a lot you could be doing, but you chose to spend it with me listening to my podcast, Menopause Reimagined. I'll see you at the next interview.